Okay, so thank you everyone for being here, and thank you to Echo for inviting me to talk. My name is Hugh Quinn. I am a clinical pharmacy specialist at WVU Medicine Endocrinology, and I was asked today to give a talk about medication coverage specific to the diabetes population. First off, just I have no financial disclosures to make. Any brand names that are mentioned in this presentation are for identification purposes only. The objectives of this lecture are going to be to review some resources that are available to people who want to determine medication coverage to help see what drugs are covered by what plans to try to make it a little bit easier. It can be a little bit of a guessing game, so any help you can get is good. We'll discuss some specific medications that often require prior authorization, some that are commonly used in the diabetic population, and try to give some tips and guidance on how to get more favorable outcomes when submitting these prior authorizations. And then we'll open it up to any questions that you guys have. So I just wanted to open up talking a little bit about the financial cost of diabetes. It's a very expensive condition to treat. These data are a little bit outdated from 2017, but then the estimated cost of diabetes in America was $327 billion. So that's with diagnosed diabetes. So you have to add into that all the patients that are pre-diabetic or are undiagnosed. So a really substantial cost of the healthcare system. The cost of treating a patient with diabetes is estimated to be 2.3 times greater than those without diabetes, so a significant greater cost. In fact, $1 out of every spent on healthcare is used to treat either diabetes or the complications that are associated with diabetes. And just in terms of glucose-lowering drugs alone, that cost in the US in 2017 was estimated to be $57.6 billion. So that's just glucose-lowering drugs, not all the complications that go along with diabetes. Like I said, this data is from 2017, and those numbers are likely only increasing pretty substantially. And they're increasing because this has been the trend throughout the country over the years in terms of the diagnosis of diabetes and the amount of patients that have it. So you can see a pretty substantial increase even from 2004 to 2016. So the number of patients that have diabetes is really increasing rapidly. And also costs are increasing because the numbers of medications we have to treat diabetes is also going up, which is a good thing. We have more tools in our box to use to help these patients, but those new medications do tend to have higher costs associated with them. So that's another reason, two hits to the system to why diabetes cost is going up so rapidly. We have a lot more people and we just have more drugs that tend to be more expensive to treat them. Like I said, with diabetes, it's not just the glucose lowering drugs that are expensive. It costs a lot to treat the complications with diabetes. So the cost to treat a patient over a 30-year period with diabetes is estimated to be over $47,000. Most of that is to treat macrovascular complications, but there's also a variety of other complications that can be pretty expensive to treat. You can see a little table here, just divides up the cost of treating diabetes, and within the red box you can see that even if we take out insulin and just consider other anti-diabetic medications and other prescription medications, the cost there for treating patients with diabetes is substantial. So I just wanted to talk about the cost there for diabetes and see how much it is, because with the cost going up so high, it's a real burden on the healthcare system. And if we need to use our resources responsibly, unfortunately, we have to limit what we can spend. And in order to do that, that's where the prior authorizations and the quantity limits and things like that come in from insurance companies. So it's not that they're trying to make our lives more difficult. They are just trying to make sure that we use the resource that we have responsibly. It would be nice to be able to use any medications that we wanted in any patients, but it's just not practical in reality with the limited funds that we have to treat patients. But there are some ways we can help navigate the system a little more easily. This is one app that is out there available for download. You can download it on Android systems through Google Play or through iPhones on the Apple Store. It's an app that you can use and you type in the medication here. So I use this example of Ozempic and then what state you're in and whether you're looking for commercial or Medicare, Medicaid coverage. And it gives you a list of different plans, and it tells you, you can see on the right here, if the medication is preferred or if it requires a prior authorization or has step therapy. So this can be a pretty helpful tool if you're just starting out and trying to figure out if medication is covered by certain plans. I am told this is not always 100% accurate. Nothing within this app is written in stone. It is a third-party app, so it might not be exactly up to date all the time, but I think it is a good resource to use to sort of start things out. Other programs are available to help with the cost of medications. I'm sure most of you are probably familiar with GoodRx, but another one that's out there is the HealthWell Foundation. So this is a foundation that is used to help with the financial costs of treating different disease states. And there's open funds for over 80 different disease states, ranging from osteoporosis to diabetes, hypercholesterolemia, and more rare disorders also. So it's a really great foundation that if you have the opportunity to use it, is great. One thing about it though, when they run out of funds, the assistance for that disease state just closes down and you're not able to apply anymore. But it's pretty easy to use. And one thing I like about it is it's used to give financial assistance to treat the disease state. So to treat hypercholesterolemia, the funds aren't associated with using a specific drug. So if you get approved to treat hypercholesterolemia through this program, patients can use these copay cards to help with the price and the affordability of any medication that they're on. So they don't have to be on Repatha or they don't have to be on Praluent. They can use these cards to get any of the cholesterol lowering medications. So it can be a really good fund to use for patients. Each different fund has different requirements to be accepted within it. This one here for hypercholesterolemia in Medicare patients, they award a maximum of $2,500. The household limit income is 500% above the poverty level. So that's pretty high compared to most copay assistance that we see, commonly like 300 or 400% above. So a lot of patients probably would qualify for this, and it can be really good in helping reducing the costs of some of their cholesterol medications. When trying to determine whether medications are covered by Medicaid, this is something that updates very frequently and very state to state, so it can make things a little bit more complicated. So I tried to provide some links here for people. These will go out within the slides, but with these different Medicaid programs, if you click the link, it'll bring you to the state's preferred drug list website. So I'll just do a quick example here. This one for West Virginia Medicaid patients. And then if you scroll down, it updates pretty regularly. This list for West Virginia was most recently updated April 1st. So if you click on that list, it gives you a list of all the preferred and non-preferred agents. So I like to just use the Control F find function, and you can just search something like Jardiance, and it'll tell you what the preferred agents are for that therapeutic class. So you can see in West Virginia Medicaid, Farxiga, Invokana, and Jardiance are all preferred medications. So it can be a good resource just to, if you're trying to figure out what drugs within a certain class are covered within your state. We can try Maryland for another example here. Each state looks a little differently on their website, but they all are pretty easy to use. Just an example here, we'll go Maryland, their preferred drug list. You can search anything, let's try Ozempic. And you can see here, Ozempic, this column here is the non-preferred agent. So in Maryland, Medicaid is a non-preferred, Ozempic is not preferred medication, but it gives you the list of medications that are preferred here. So you can see Trulicity is a preferred option, Victoza also, although it has quantity limits, and that's just so you're using the doses to treat diabetes, not obesity, which would be the 6-enda agent. So using these preferred drug lists can be a good resource to try to determine what the preferred medications are, so you can avoid going through the prior approval process. I tried to use those resources to summarize the data a little bit and give some information about the common classes of medications used for diabetes. So here you can see the coverage for the SGLT2 inhibitors in West Virginia, Maryland, Pennsylvania, and Ohio. You can see they are all are preferred medications, although some like Pennsylvania do still require prior authorizations, and they do have quantity limits on them. And then there are savings programs out there that are available for patients that have commercial insurance. They can be kind of cumbersome to fill out, but if you have somebody that's able to do it with your patient, that's very helpful. A lot of times they ask for income information, which a lot of patients might not be comfortable giving out, but the links are here to bring you to the applications or the sites with the applications on them if you're interested. Most of them do have limits on how much they will cover. You can see here the Janssen program for Invokana does have a $3,000 a year maximum. So once the patient hits that, it would be all out-of-pocket costs. And then similarly here with the GLP-1 coverages, you can see Trulicity is generally the preferred agent throughout all the states. Then you can see Ozempic, Rybelsus, non-preferred. Doesn't mean that you can't use them. They just would require prior authorization to be used. So keep that in mind. And again, here's some savings programs for those agents that you could use in your patients if they have commercial insurance. With the GLP-1s, I think one of the reasons Trulicity is probably the preferred agent in most places is that it has a unique indication where it's approved to reduce the risk of cardiovascular events in patients who have established cardiovascular disease or multiple cardiovascular risk factors. So that means it's indicated as an agent in primary prevention. So you don't need to have a history of cardiovascular events. Trulicity is the only agent that is approved for primary prevention. And the reasoning behind that isn't that the other medications don't work. It's just that when they did the original studies, the percentage of patients that had or did not have a history of cardiovascular events was higher in the Trulicity study. So they had about 30% of patients that were primary prevention, whereas the other studies for Ozempic and Victoza, it was lower. It was only 20 and 10%. So the FDA was not able to grant Ozempic and Victoza that indication just because they didn't have as robust data in primary prevention, whereas Trulicity, with 30% of their patients being primary prevention, the FDA felt comfortable giving that indication for primary prevention. So not that Ozempic and Victoza don't prevent cardiovascular events in that population. The data just isn't out there that the FDA was comfortable to support that indication. Now, I want to talk about those two medication classes specifically because they're really great options for our diabetic patients. They work well to lower A1C, but with the new updated diabetes guidelines, we might start seeing them more commonly used and earlier in therapy. So there's been an update to the wording with the diabetic guidelines where the first line therapy depends on comorbidities, patient-centered treatment factors, which includes cost and access, and generally includes metformin and comprehensive lifestyle modifications. So it doesn't say that first line therapy has to be metformin anymore. This kind of opens the door for us, for our patients that have cardiovascular risk factors or chronic kidney disease, to use these other agents that have additional benefits like SGLT2 inhibitors and GLP-1 inhibitors as first line therapy. So these updated guidelines are recommending that we may be able to get around step therapy where we have to use metformin first, and we may be able to get aggressive early in therapy using the SGLT2 inhibitors and GLP-1 receptor agonists, possibly even in combination, and getting really aggressive early in treatment to help control our patients. Another medication class that I want to talk about that you might not necessarily consider as a diabetic medication, but we all know diabetes is not just A1C. There's a lot goes into it, treating things like blood pressure, weight loss, and cholesterol. So I want to talk a little bit about the Pcsk9 inhibitors. These medications are a good tool for us to use for our patients we need robust LDL lowering. Unfortunately, the access to them has been a little difficult in the past, although it is getting a little bit easier. With these medications, they are approved for secondary prevention in patients with a history of ASCVD, but also for primary prevention if they have familial hyperlipidemia. Repatha is also approved for patients over the age of 10. Praluent is only over the age of 18. So if you have pediatric patients, Repatha may be an option for you. And where this comes into play in the guidelines is with in diabetic patients. The ADA recommendation is for secondary prevention if they're on a statin and their LDL is not less than 70, or if they are on maximal LDL lowering therapy and their LDL is still above 70. And also with the ACE recommendations, it's in patients that are on maximally tolerated statin, which can be no statin, which we'll talk about later, and not below threshold. So what are those thresholds for the ACE recommendations? And that's this chart here on the right. These are what the ACE guidelines are, a little bit different from other guidelines, where they don't just recommend high intensity statins or a certain percent reduction. They're really looking at these hard LDL thresholds that we want our patients to be below. And you can see here, if you look at the very high risk category, patients with diabetes and just one or more risk factors. So that can be obesity, hypertension, dyslipidemia itself is a risk factor, family history. So just one risk factor plus diabetes, which is pretty common in most of our patients, I think, is going to set their threshold at less than 70. So pretty aggressive with their LDL recommendations for patients. And a lot of patients maybe don't tolerate or aren't able to get below that with statin therapy alone. So they really need additional therapy. And you can see in the extreme risk category above, that's where they're really getting very aggressive. So that's mostly for patients that have diabetes plus CKD or diabetes and established cardiovascular history. So we're getting really aggressive there with LDL thresholds less than 55. And that's not realistic for a lot of patients to be able to do with just oral LDL lowering therapy. So that's where these PCSK9 inhibitors can really come into play. And I think it's a good place to help with some clinical inertia, and can be a good opportunity for those providers who are treating diabetes to start these medications in their patients and get aggressive and use it, not just waiting for cardiology or somebody else to start it, but getting aggressive for those who are treating diabetes to also treat the LDL and the cholesterol targets in these patients also. In terms of getting these medications approved in secondary prevention, it's easy. So if your patient has a history of cardiovascular events, it's fairly easy to get approved for these medications. In primary prevention, it's a little bit more difficult and might need to get a little creative. One of the things I've noticed is that any plan that's managed by Express Scripts, they will require a coronary artery calcification score above 300 Agaston units. So where that information comes, or that line in the sand comes from, I'm not really sure. It was negotiated in their contracts that they need this coronary artery calcification score above 300. Doesn't matter any other characteristics, they're going to hang their hat on that one. And I've also found commonly that they don't pay for the test. So patients have to pay out of pocket for the test, but once they get the test done, if they do have this score above 300 with Express Scripts, it will be covered. Also, you can keep in mind that if they have a history of LDL greater than 190, whether that's treated or untreated, if it's a treated LDL less than 190, and you can make the argument that untreated would have been greater than 190, so if they're on a high intensity statin and their LDL is in maybe the 150, 160 range, you can certainly say that if they were not on a statin, they would have an LDL over 190. These patients should be screened for familial hypercholesterolemia, which is also an indication that these agents are approved for primary prevention. So if you can diagnose them with familial hypercholesterolemia, the approval process gets a little easier. And one thing to help out with that is this Dutch lipid score calculator. Most of it's based on patient history and family history, but it's a risk score calculator to help diagnose with familial hypercholesterolemia. And if you get a score of at least 6, most plans will accept that as diagnostic and will approve it. Some plans have required a score as high as 9, which means they have definite familial hypercholesterolemia. And one thing to look out for when doing this risk assessment are tendon xanthomatosis and arcus cornealis. So if they have these cholesterol deposits in their joints, either in the Achilles or the hand or in the knee, that gives you an automatic 6 points, which would make you have at least probable familial hypercholesterolemia. And this arcus cornealis, also the grayish blue ring in the pupils of the eyes. So if you're doing a physical exam on a patient and you're considering treating their cholesterol, it's a good idea to keep these in the back of your mind, as well as doing a pretty thorough family history and patient history. So when it comes time to do the prior authorization, you have that information and it can improve the favorability of the outcome. Another medication I want to talk about that has some issues with insurance approval is Vasipa. So Vasipa is an esterified form of omega-3 fatty acid. It is pure icosapent ethyl. It does not contain DHA itself. And this medication actually has 2 FDA-approved indications. One that's been around for a long time, which is to treat triglycerides in patients with hypertriglyceridemia, so levels above 500. But in the diabetic patient population, that's really not what we're concerned about, and most commonly not what we're going to be using the medication for. Where Vasipa comes into role in diabetic patients is to lower the cardiovascular risk in patients, so the risk of MI, stroke, coronary revascularization, or unstable angina. In patients that have diabetes with other risk factors and triglycerides above 150. So it's important to keep that in mind, because if you're submitting a prior approval for these patients and you submit it for hypertriglyceridemia and their levels are not above 500, it's going to be denied regardless of their history of diabetes or risk factors. So when filling out these prior authorizations, it's important to use the indication that you're using it for cardiovascular risk reduction, not for hypertriglyceridemia. The other caveat with this medication is there's been some legal battles between generic drug companies and the makers of Vasipa. What's kind of been decided is that Vasipa is the only one with an FDA-approved indication for cardiovascular risk reduction. So the generics do not have that indication, although they are indicated for treatment of hypertriglyceridemia. So if you want to use the medication that's approved for cardiovascular risk reduction in diabetes, you have to write it for brand medically necessary for Vasipa. It's kind of odd because even the price, the average wholesale price of these 2 medications are pretty similar. For Vasipa, it's $3.55 for 1 gram, $3.55, and for the generics, it's $3.14. So not a huge discrepancy in price there. But if you want insurance coverage for the one that has the approved FDA indication, you do need to write brand medically necessary for Vasipa. I also just want to talk a little bit about step therapy and what it means. So you'll see a lot of times when you're doing prior authorizations or in indications, patients must be on maximally tolerated statin. That can be no statin. It doesn't mean that a patient has to be on statin to be on Repatha or Praluent or anything like that. Usually it does require a trial of at least 2 different statins. And to be considered an effective trial, the patient actually has to pick it up from the pharmacy. So they do have information on claim status. So if you try to say that your patient tried rosuvastatin and atorvastatin, but they've never had an insurance claim for it, the insurance company knows that and they're not likely to approve the medication. So you do have to make sure that the patients are actually doing a trial of these. Just writing the prescription doesn't count. They actually need to pick it up, pay for it, and usually wait at least 6 weeks before you can say it's a failed trial. Then when you hear things like high intensity statin, most plans will require high intensity statin failure before they approve some of the more expensive medications. And it's just important to keep in mind that with that, high dose does not equal high intensity. So our high intensity statins are only atorvastatin and rosuvastatin. Things like simvastatin 40 milligrams or pravastatin 80 milligrams, those might be high doses of those drugs, but those are not considered high intensity statins. So you need to keep that in mind when you're considering patients' statin tolerance and whether or not they're on appropriate statin therapy. And then things with step therapy, a lot of plans will request that ezetimibe is also used within step therapy, but the LDL reduction of ezetimibe, it's pretty good within 12 to 17%, but a lot of patients, this just isn't enough to get them below those thresholds that the ACE guidelines recommend. So you have a patient with an LDL of 120, they're on maximally tolerated statin, you're trying to get them below 70, Zetia alone is not going to do it. So sometimes you can make the argument that they need Pcsk9 inhibitors because they need the more robust, greater than 50% LDL reduction, and Zetia is just not going to do it for them. Some plans will approve it on that basis alone. And then I want to talk about another option that we have for these patients. Again, with cholesterol, it's a newer medication. It's working its way into step therapy. It's a good option for patients that maybe don't want to use injectables or need a little more LDL reduction than just Zetia alone would provide. It's bempedoic acid or Nexulital. It's a new mechanism of action, so it's a novel mechanism. It's actually a prodrug that only becomes activated in the liver, so it doesn't become active in the muscles, so you can avoid a lot of those myalgias and adverse effects that we see with statins. Does work within the same pathway of statins. So when it's used in combination with statin, you get pretty significant LDL reduction because you're hitting the same pathway from 2 different points. In terms of efficacy, when it's compared to placebo, bempedoic acid alone, when used in combination with statins, you get a 17 to 18% reduction. But it also comes available in a combination pill with bempedoic acid and ezetimibe combined in the one pill. And when you use that in combination with statins, you can get a 38% reduction. So this is a pretty good oral option for a lot of patients that are maybe hesitant to injections or maybe haven't been tolerant to the Pcsk9 inhibitor in the past. So a new tool that we can use to get a little more aggressive with our LDL reduction. That medication has been approved also for heterozygous familial hypercholesterolemia and for patients with established atherosclerotic cardiovascular disease. So here is also a link to the Copay savings card that is available for patients with commercial insurance if you're looking to start your patients on bempedoic acid. This card can be used for either Nexulital or Nexlizet, either one of those options. So I also just at the end of this provided like all the links that I used here. So if you're looking for them at home, you're not able to click on them or anything, they are here. But if you have any questions or you would like any more information, please feel free to reach out. Thank you.
Thank you so much, Dr. Quinn. Wow, that was really informative and you did such a great job just breaking it all down. I feel like if I was a provider, I would just keep your PowerPoint on hand as like a cheat sheet to reference. But yeah, no, we really appreciate that. Thank you.
No problem. Thank you. And things do change a lot. So this has been updated before this presentation, but who knows what next month is still relevant. But thank you.
Yeah, absolutely. And we might ask you to do like each curriculum, maybe like an update on insurance. You know, like you said, it changes so frequently. It's helpful to have a didactic on it. So we had a few more folks hop on. I see Dr. Polly Wall and Paris Turner, you both hopped on. That's wonderful. But if you had any questions, if anyone had any questions or comments, just feel free to raise hand, unmute, or chat in. I agree, Elizabeth. I saw your chat saying we should have Dr. Hugh Quinn present on this topic at least once a year, if not every 6 months.
I'd be happy to.
Thank you. The quiet group today.
Thanks, Hugh.
Thank you.
Has anyone had any personal difficulty dealing with insurances in their clinics, or what their experience has been? No pressure at all, but was thinking maybe I'll just throw that out there. Dr. Pollywall chatted in thanking you as well, Dr. Quinn. All right. Well, if there are any questions or comments afterwards, feel free to email us as well. For those of you who sort of hopped on after the announcements we had in the beginning, we're going to disregard my last recap email that said the time change of the sessions. We'll keep them at 12 to 1. And then Elizabeth kindly chatted in the CME form. The CE office at WVU reached out to us, and they're implementing a new form for anyone who's interested in receiving CME credits for any of our echo sessions or any project area, I should say. So you just have to go to that link she chatted in, fill it out only one time. You don't have to do it one time per session, just one time is perfect. So if you want to take a moment to fill that out if you're interested in CE credits. My only announcement is that the next time we'll meet is on June 8th, and Dr. Haydar will be presenting on when and how to prescribe U500 insulin. Not entirely sure what that is, but that's the title. So